Hello, everyone. My name is Teddy Milgram, and I'm happy to welcome you to the 8th annual Cannabis in Practice webinar series hosted by Washtenaw County Health Department. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for 1 Pain and Symptom Management Social Work Credit, 1 McBAP Related Credit, 1 Mishwa CHW Credit, and 1 CHES credit. If you are requesting any of these continuing education credits, you are required to attend the full session. Attendance will be verified through Zoom Analytics. If you are not requesting CEs, you can choose to receive a certificate of general attendance. A completed post-webinar evaluation is required to receive CE credits or a certificate of general attendance. A link to the evaluation will be shared at the end of the session. Please note that the evaluation survey must be filled out within 7 days of the session for which you are requesting credit. Certificates will be sent out via email within 30 days. Once you receive the email, you will have 30 days to download the certificate. To review some housekeeping notes, all participants will be muted throughout the session. If you require a live transcription, please select the Show Captions function. If you don't see it, resize your window to be wider. Please ask all questions for our speaker through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer questions. This webinar is being recorded. The webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. I am pleased to introduce today's speaker, Dr. Kevin Boehnke. Dr. Boehnke is an assistant professor in the Department of Anesthesiology and the associate director of the Michigan Psychedelic Center. His current research focuses on therapeutic applications of cannabis and psychedelics, with the goal of rigorously assessing their therapeutic value and addressing public health harms caused by their criminalization. None of the planners for this educational event have any relevant financial relationships with ineligible companies to disclose. And now I'll turn it over to Dr. Boehnke to share his disclosures.
Thanks so much, Teddy, and really appreciate the opportunity to speak here today. I am currently supported through some grants through the National Institutes of Health, as well as through the State of Michigan Cannabis Regulatory Agency. I received some protocol development funding from Trip Therapeutics, as well as an honorarium for a podcast on fibromyalgia from Viatris Inc. All right. And so with that, I'm going to share my slides and we'll get going. So today I'll be talking about approaching cannabis for chronic pain management. And just so we're on the same page, linguistically, people talk about hemp, cannabis, marijuana. All of these refer to cannabis sativa. Designation-wise, hemp tends to refer to cannabis that has less than 0.3% THC, which is the main psychoactive component in the cannabis plant. and I'm making this designation as well because these products that have less than 0.3% THC tend to be descheduled. They predominantly initially contain CBD or cannabidiol, but now contain a whole alphabet soup of different other cannabinoids, some of which I'll talk about. And in contrast, there is the term marijuana refers to cannabis or cannabis preparations that have more than 0.3% THC. This term was used in the cannabis prohibition campaigns. Um, and in this talk, I'll probably use neither of these. My plan to just it will be to use cannabis as this is the most scientifically accurate, and then it doesn't have the baggage of being used in, cannabis prohibition campaigns or other things of that nature. So just a little bit of historical context, especially as it relates to cannabis and pain. So we've known that cannabis has been used for pain and analgesic properties for literally thousands of years. So the first recorded medical use was in China in somewhere around the 2700 BCE, and part of its uses were for arthritis and rheumatism. This use continued through antiquity with the Greek physician Galen prescribing cannabis as medicine, and then actually was in the US pharmacopoeia for quite some time until the 1930s when the Marijuana Tax Act was passed, and thus the many, many cannabis-based formulations were removed from the US pharmacopoeia. As time went on, and cannabis was first criminalized under the Controlled Substances Act under 1970, in 1970 in the US, it subsequently started in the 1990s, was approved for medical use in a number of different states, creating quite a mismatch between state and federal law. There are also some FDA-approved medications based on cannabis, including dronabinol, which is synthetic THC, that were approved for various medical indications, despite the fact that it has the exact same active ingredient as the cannabis plant itself. So this interesting mismatch has contributed to research environment in particular that the science has always persistently been a bit behind, especially when we have states that have been passing medical cannabis laws that allow access to cannabis for pain and other different conditions. So with that kind of grounding, I wanted to share the outline for the talk. So I'll go a little bit into more depth about the current legal situation, as there have been some substantial changes, especially in the last few months. Talk then about some cannabinoid effects and ingestion methods and how that can affect the sorts of outcomes or effects that people end up having. Talk about management, talking about both clinical trial evidence as well as some trends that have showed up in real world use. I'll discuss some stigma and barriers that have gotten in the way, especially historically, of appropriate implementation of cannabis in medicine, and then finish with a summary with some practical tips around how to engage with people using cannabis in the pain context, as well as some novel designs that are being used to study cannabis in the pain context. So, cannabis in the US. At this point, there are very few states that have no programs that allow some sort of cannabis access. There are over, I believe, 40 states with legal medical cannabis, about 24 with legal adult use cannabis. And as of April 23rd, the Justice Department placed both FDA-approved marijuana products or cannabis products like dronabinol and products containing cannabis subject to a qualifying state-issued license into Schedule 3. So they rescheduled it from Schedule 1, which is by definition, holds substances that have no accepted medical value and a high potential for abuse or misuse, and place them in this less restrictive category, which acknowledges the potential therapeutic benefit of cannabis. So this is an enormous policy change. Probably one of the most consequential cannabis-related policy changes that has happened in the past 55 years. And in part, this is exciting on the research side of things because ideally this would mean that research on cannabis, both for pain but also other therapeutic purposes, will become easier. But there's a lot of unknowns about how this might be implemented. For example, none of the products that are available in dispensaries can be prescribed by physicians in Michigan, for example, because none of them have been approved by the FDA. So we're still in the same scenario as before, just the products are rescheduled, and how this rolls out remains to be seen. Hopefully, it will allow for some better research. But an incredibly important thing that I want to mention here as well is that in addition to stifling the ability to assess the therapeutic benefit, and in some cases the harms of cannabis, um, the criminalization of cannabis for the past 50 plus years has resulted in a broad range of psychosocial outcomes, including incarceration, um, and which also has downstream effects like depression, anxiety, trauma-related psychiatric symptoms, years of life lost, economic and family and social ties related issues, as well as some things like voting disenfranchisement. So this change that has been happening from a public health standpoint of medical and then adult use cannabis, the way that that has affected the trends in mass incarceration have been significant as a sort of broader context to thinking about the therapeutic application of cannabis in specific medical conditions. And so just a little bit of data showing how this liberalizing of cannabis policy has affected cannabis arrests. So in green, you can see the states that have legalized adult use cannabis. That big green arrow shows the mean arrests in states per 100,000 residents in 2025. While in contrast, all the states that are the red lines, the mean arrests in those states is much, much higher. So this shows the one key public health impact of cannabis legalization. Now, when we focus in on the medical context, which is the bulk of what we'll be talking about here today, it's worth noting that there's just been a dramatic growth in medical cannabis licenses and patients. So, for example, since from 2016 to 2022, there's over 600% increase in the number of licensed medical cannabis patients in the US. And these data my colleagues and I pulled from all the publicly available registries across the nation, but they notably excluded California, which is the largest state population, as well as that has it has the largest state population as well as the longest standing medical cannabis law. So this is likely an undercount of the total number of medical cannabis patients. And if we look at the reasons why people obtain medical cannabis licenses, the most common reason is for chronic pain. So in 2020, a bit over a million of these patients reported using cannabis for chronic pain. I do want to note that, the reason why this doesn't add up to that, almost 4 million people is because not all states actually report the conditions why people obtain medical cannabis licenses. But you can see that this is the predominant condition for which people obtain medical cannabis licenses. And in Michigan, this is no different. So we've had the Michigan Medical Marijuana Act since 2008, covering many conditions or symptoms. The way that this works typically is people will go to their clinician or to some of the pop-up clinics that have shown up that specifically do medical cannabis licenses. If they have a condition that qualifies them for medical cannabis access under state law, that clinician will sign off on a form. The patient will send that and a fee into into the state, and they'll get a medical cannabis license. As of June 2026, there are about 52,000 patients in Michigan, and people can select more than one condition or symptom in their application. So 71.9% of patients in Michigan indicated chronic pain, 39.4% for severe and chronic pain, and 19.6% for arthritis. So just showing the predominance of licensure for pain in Michigan. And of course, another key piece of context here is that we have an adult use law. The key aspects of it, which are overviewed in this infographic, so people can possess and grow cannabis. Adults can have 12 plants in their home, 10 ounces at home, 2.5 ounces of cannabis in public, and should not be smoking in public areas or while driving a vehicle. But employers can still drug test. And I mentioned the context of the adult use law as well, because this is something that is showing up nationwide as the number of patients decreases substantially after adult use law is passed. This is a trend that shows up nationwide, and Michigan is no different. So you see with the green star, that's the year that our adult use law passed. Dispensaries opened in 2019, and each year subsequent, there's just been a massive decrease in the number of patients. And so this, in some ways, begs the question of, well, for what reasons are people obtaining these licenses? Is there something about the adult use market that is, causing people to just decide they don't want to renew their license? Is it perhaps they don't want to pay fees? Is there something else going on? These are all open questions, but it's just worth noting that, from the heyday of almost 300,000 patients in 2018, we're now down to below 60,000 in 2026. So with that context then, and some of those rapid changes that are going on at both the state and federal level, let's talk about how cannabinoids affect the body. So I've already mentioned THC and CBD. THC, or delta-9 tetrahydrocannabinol, is analgesic, it's mood altering, it's appetite stimulating. There are FDA-approved formulations that are synthetic, such as Marinol or Dronabinol, which is synthetic THC. In contrast, there's CBD, or cannabidiol, which is a non-intoxicating cannabinoid. It is FDA approved as Epidiolex, which is a potent anticonvulsant for orphan epileptic conditions. It is descheduled because it has basically no known abuse potential, and it might actually be somewhat protective against some of the psychoactive effects of THC. And there's a lot of excitement about the effects of CBD in various different spaces, including in the pain space, given that preclinical studies have demonstrated that it has strong anti-inflammatory activity. Now, there are numerous other cannabinoids found in the cannabis plant, over 100 different ones, such as CBN, CBG, CBC. I'll talk about those a little more on the next slide, but something to mention here that is important clinically is that when people are using cannabis-based medicines, there's a variety of different products available, and people often talk about the so-called entourage effect. Like, the idea behind that is, in classic pharmacology, we like to isolate a specific compound and say, okay, we want to attribute all the effects of this. We want to understand what this molecule does specifically so we can attribute effects to it. But of course, the cannabis plant is much messier, having over 100 different cannabinoids that have been found in it. So patients will say, okay, should I take, a THC isolate, or should I take a full spectrum or a whole plant extract? And the idea being that entourage effect is all those pieces, all those different cannabinoids, terpenes, whatever they might be, they potentially work together to create a sort of different effect. We don't have an enormous amount of evidence suggesting that in like head-to-head studies suggesting that those products might do something different, but it's definitely something that shows up clinically and worth mentioning. Um, there are many other cannabinoids that people are starting to use. So my colleagues and I did a nationally representative survey and asked about use of cannabinoids besides THC and CBD. And we found that delta 8 THC, CBG or cannabigerol, and CBN, cannabinol, were used by a substantial portion of the population in the past year. So delta 8 THC, this is a semi-synthetic cannabinoid that's quite similar to delta 9 THC, but reportedly less potent. It's typically not available in dispensaries because they can just sell delta 9 THC, but is often available in the semi-illicit markets, online, elsewhere. And there's been quite a bit of work at both the state level and concerns from the federal level saying, hey, we need to do something to regulate these products like Delta 8 THC or other intoxicating cannabinoids that have started proliferating in the market after after the products that are made from hemp that have less than 0.3% delta 9 THC, after there's the discovery that those can be converted into other intoxicating compounds. And so I'm not going to go much more into it there, but just to note that, these products are out there and are being used. Cannabinol is a non-intoxicating compound. This is plant-derived. And there's actually been some clinical trials with CBN that suggest it might be useful for sleep. Unfortunately, it's tough to tease out the effects of cannabinol on itself, on its own, because the studies that use it typically co-administer with THC. Um, and then lastly, CBG or cannabigerol. There are very limited clinical trials using this compound, but some preliminary effects have been demonstrated with stress and anxiety. Like CBN, this is available in dispensaries. And so, as you are thinking about and working in this space moving forward, keeping an eye on these newer, more emerging cannabinoid products is something that patients are asking about, and will be worth, keeping an eye on the literature moving forward. But unfortunately, not much there at this point in time. So in terms of how these compounds are ingested, so typically smoking, oral mucosal, or topical applications. So the table beneath the picture of each summarizes some of the key factors here. So when inhaled, cannabis has a quick onset and a fairly quick duration of effect. Onset almost immediately, 5 to 10 minutes, with duration about 2 to 4 hours. When taken orally, it's much slower, 1 to 3 hours for full effect. The duration 6 to 8 hours, but sometimes even longer, depending on the dose. And so there's a lot of use of things like gummies, or cookies or beverages, which are quite discreet. But one of the key challenges associated with these products is that they have that delayed onset. And so people will eat some, not feel anything, eat more, feel a little bit, eat more, end up in a situation where they've eaten too much and are having a challenging time. Kind of scratching the fence between ingestion and smoking is the oral mucosal or tincture sorts of roots. When held in the mouth for 2 to 3 minutes, these can have a faster onset than ingestion, and they last a similar amount of time, especially if they're swallowed afterwards. There are some pharmaceutical uh, oral mucosal forms that are available but not in the US. So, classic example of this is nabiximols, which is available in dozens of countries. It's a one-to-one CBD to THC sublingual spray, but it's just not available in the US. And then lastly, topical products, which um, we don't know a huge amount about the onset and duration just because these products are just so widely variable in formulation. And so the conventional wisdom at this point is, they likely have a less systemic effect unless they have some kind of additive that allows them to penetrate the skin. So people tend to use them for localized symptoms at superficial joints like knuckles, elbows, knees. All right, some risks of cannabinoids. Um, so in the long term, respiratory effects of smoke. So inhaling a heated, combusted plant material, not great on the lungs. Despite some claims to the contrary, cannabis does have risks of dependence and addiction. About 9% of people who use cannabis during their lifetime have some kind of issue with dependence, and that increases quite a bit if use starts in adolescence or in a heavy chronic way. There are some individuals who there appears to be a relationship between development of psychotic illness and use of cannabis, especially if use starts under the age of 25. The causal relationship there is somewhat uncertain at this point in time because there's quite a bit of use of cannabis products for psychotic illness, especially CBD predominant products. But regardless, I think at this point, the evidence is suggestive that there's at least a subset of individuals who will certainly have some kind of worsening of psychotic symptoms if they ingest cannabis. And then something that has really shown up is incredibly important and concerning, especially since the last time I gave this talk several years ago, is cannabinoid hyperemesis syndrome. There's been a lot more study of this in the past several years. This is a cyclic vomiting condition that will show up among people who are typically in that chronic heavy use pattern. There may be some genetic components associated with it, but there's a lot of unknowns, unfortunately, about who develops this. And unfortunately, there's not great treatment. The most effective treatment is abstinence, with a little bit of work suggesting that, use of heat like a hot shower can help with symptom cessation, but the only long-term way to stop it is with abstinence. In the short term, there are many common side effects: dizziness, sleepiness, euphoria, lightheadedness, anxiety. Less commonly, things like vomiting, paranoia, or hallucinations. But uncertain quality of product is really important to think about here, especially in the illicit market. Um, and then lastly, getting high and getting behind the wheel of a car, operating heavy machinery is also not going to be a wise choice. I'm going to differentiate some of the risks of CBD and other cannabinoids just because most of those risks that I just talked about were drawn from studies of recreational use, or non-medical use, I should say, and typically with THC-based cannabis, which is unfortunately where the bulk of the literature is at this point in time. So, when thinking of CBD and other cannabinoids, the risk profile is quite different. So, as I mentioned, there is a descheduled CBD product. This is generally well tolerated, including at very high doses, over 600 milligrams per day. Um, CBD does have known drug-drug interactions, though. It can inhibit or affect liver enzyme activity, which can affect CBD plasma concentrations. And at high doses, can cause a swath of different, generally fairly minor side effects, although some people do end up with elevated liver enzymes, especially when combined with medications like valproic acid. So very important, especially with taking CBD at high doses to monitor for that. And for many of these emerging cannabinoid products, especially again those bought more in the hemp market side of things, not through dispensers. There can be quality control issues, so contamination with pesticides, solvents, heavy metals, synthetic cannabinoids that have uh, much more potent effects than THC, as well as legal issues. So, even though these other cannabinoid products tend to have less than 0.3% THC, that can still be enough for a positive drug test. And these drug tests are, unfortunately, they capture historical use rather than current intoxication. So, somebody who used cannabis, say, 2 weeks ago, might still have a positive drug test. And it's very possible to have a positive drug test from a fully legal descheduled CBD product. And because drug testing is sometimes still mandated, even if cannabis is legal, this can result in employment consequences. So, thinking about this as a real risk to convey to patients, I think is super important. All right, let's talk more then on the pain side of things. So, at the center that I work at, the Chronic Pain and Fatigue Research Center, and the Michigan Psychedelic Center, we think of pain coming in three sorts of flavor. So there's nociceptive, neuropathic, and nociplastic pain. So nociceptive pain is typically related to tissue damage or inflammation. The pain is well localized and consistent with the effective activity on pain, so like a bone break or osteoarthritis of the knee. In contrast, neuropathic pain is caused by nerve damage or entrapment. It has more of a lancinating or numb or tingling sort of character to it. And a classic example of this is something like carpal tunnel or sciatica. And then lastly, there's nociplastic pain, which is thought to be a central nervous system or systemic problem. And unlike nociceptive or neuropathic pain, the pain is accompanied by a cluster of difficult to manage symptoms, including fatigue, sleep, memory, or mood difficulties, as well as a history of pain elsewhere in the body. So the pain seems to move around and be difficult to manage. So the classic example of nociplastic pain is fibromyalgia. Now, all of these can co-occur together, and as you can see, they have different sorts of treatments that might be best to target at these different symptoms. But when they co-occur together, somebody might have arthritis, they might have a repetitive motion, carpal tunnel injury, and underlying fibromyalgia. So this can complicate the way that clinical treatment occurs. And but this can be instructive as thinking about how we do more precision analgesia approaches. But unfortunately, this sort of thinking about pain has not really been translated into many of the clinical trials with cannabis because, as mentioned, they have been quite restricted historically due to the way that, well, to cannabis criminalization as a Schedule I compound. So, in the systematic review and meta-analysis conducted by the premier pain professional society, the International Association for the Study of Pain, they looked at all the existing trials at that point in time and they said, hey, these trials are of short length, small sample size. They have generalizability issues because they don't use products that are representative of what's on the market. Many use THC alone or a combination of THC and CBD. But they suggest that these products are most useful in neuropathic pain. And similar to the side effects and risk profile that I mentioned earlier, they did have some short-term AEs for study participants, but nothing major and nothing lethal, which is consistent with what we know about cannabis. It's extremely difficult to overdose and have a lethal event from cannabis. Now, since this systematic review and many other systematic reviews have been published, there are two really important studies that have come out in the past year. And so these were two phase 3 trials in chronic low back pain, a condition in which there had not really been almost any cannabis studies, clinical trials conducted. And the product that was used has been granted breakthrough therapy designation by the FDA in the US. So I believe there's still going to be another clinical trial coming, but assuming that trial shows positive effect, it's possible that there will be the first cannabis-based medication approved specifically for pain in the US sometime in the next few years, which would be a remarkable change, especially because this product is a THC dominant product. So the first study was published in Nature Medicine, um, and I've showed one of the key graphs from that paper. You can see in purple, that's the group that received the THC-based product. The gray line is those who received placebo, and you can see a marked difference between baseline, that first blue period, and week 15, that second blue period. So as well as then in the open label extension, when everybody receives THC, that THC-based product, there's a continued decrease in pain symptoms over time. Um, I'm not going to go too deep into this table because there's a lot here, but basically what it shows is in these individuals, the people who received the THC-based product had better pain response, less use of rescue medication, better sleep outcomes, and overall they perceived it as being more helpful with their symptoms than placebo. Um, and so this was an incredibly important study. The second one that followed it, actually, instead of testing against a placebo, this company decided to test their THC product against tailored opioid treatment. So there's been a lot of talk and thought in this space of, cannabis as an opioid alternative. I'll show some observational literature that talks about that same thing. But because opioids have been used so much in the past years to treat chronic pain, despite their risk of lethal overdose, it was incredibly exciting to see an actual head-to-head comparative study. And what this one showed is that this THC product significantly outperformed opioids for pain, sleep, and safety, with the primary outcome being gastrointestinal safety, including things like constipation, and then use of laxatives to help with constipation, which is consistent with the side effects of opioids. And so you can see in this figure, there was a significantly higher percentage of individuals who had constipation in the tailored opioid treatment versus those who received this THC-based product. And then similarly, there's a lot of different graphs. You can see that people receiving VER01, that THC-based product, had decreased pain intensity and improved sleep quality compared to those who did not. So, all that being said, that product is not yet available in the US. And so the clinical trials that were included in the systematic review that I mentioned were things like Epidiolex, Marinol. If you look at the gentleman in that bottom photo, that's Dr. Mahmoud El-Soli, who runs the National Institute on Drug Abuse funded site at the University of Mississippi that provided the only research-grade cannabis in the US for many years. The powder that he's holding is cannabis that was used in inhaled cannabis studies. These products look much different than what's available in dispensaries. So edibles, high potency flower, cosmetics, beverages, so many different things. And so this generalizability issue becomes more clear too, both based on the differences of the products, but the way that they get used. So my colleagues and I surveyed over 1,300 people using cannabis for chronic pain. And as you can see in that bottom table, most people use two or more different methods of cannabis ingestion or administration, I should say. Anything from smoking, vaporizing, edibles, topicals, or tinctures, to various combinations of each one, and different cannabinoids as well. So instead of just THC or just CBD, they would use different ratios of these compounds. We also did a deeper dive asking people about the sorts of routines that they had with cannabis. And as demonstrated in this table, some people got pretty complex. So while some had simple routines like, taking a couple drops of CBD oil twice a day, some people took gummies, then vaped, then microdosed every so often with a vape pen. Then they came back and, vaped some more and used a water vape and took a gummy and that was more focused on sleep, a THC indica gummy. And so it's difficult to capture those sorts of very complex real world based routines in the context of a stringent clinical trial where you typically, give people a specific product in a different way, in a distinct way, and assess their outcomes to that standardized regimen. Now, the last trend I want to highlight that I already mentioned is that idea of using cannabis in place of other medications. So this is among that same 1,300 people who I already mentioned. We asked them, did your use of other substances change as a result of your cannabis use? And 691 said that they had actually substituted cannabis for opioids. About 70% said they totally stopped using opioids as a result of that substitution. Similar trend held for benzodiazepines and gabapentinoids. Quite a few people use these for other medication classes as well, such as SSRIs and SNRIs. This same trend held among individuals who were using CBD products for fibromyalgia. So this was among 878 people who my colleagues and I surveyed through a large survey with the National Fibromyalgia Association. And a little bit less dramatic decreases. So about 50% of those who had substituted CBD for opioids reported cessation, and similar with benzodiazepines. But this trend showing up also in the context of people saying, "Hey, I'm using cannabis or I'm using CBD because it's better for my symptoms and I have fewer side effects associated with it than my use of these other medications." So if I and my team were the only ones who had come up with these results, I'd be quite skeptical about them. But this is just a tiny sampling of the dozens, if not hundreds, of papers at this point that have talked about and looked at this substitution effect. To me, this suggests that this is not universal, but that there's at least a subset of individuals who, when using cannabis in the pain context, especially those who are probably responders to cannabis, that they are able to successfully do this substitution. But of course, there are individuals who will add in cannabis and have no pain response, or who will have perhaps worsening symptoms or something else going on. So this by no means should be interpreted to say that cannabis is one for everyone, or two, that it has this effect universally. All right, so let's talk then about the clinical context a little bit. Um, so stigma and barriers to understanding and integration into medicine. So, in terms of stigma, we've have many, many years of this in our society, from reefer madness to just say no to whatever it might be. This propaganda around the effects of cannabis. And in many cases, especially still now even, if a patient discloses cannabis use instead of being asked, well, how does that interact with your symptoms? Are you using it medically, or what is your purpose for using this? That just might be a direct line to addiction services. So people will choose not to disclose for that reason. Um, and also, they might not want to disclose because of legal issues. So you don't want to talk about your use of a Schedule One substance with a healthcare provider. There's no insurance coverage, so people either pay for these things out of pocket, or they grow it themselves, or um, I guess they can do something else. But there's not there's not a lot of options, especially for those who are on a fixed income or who have fewer financial resources. In Michigan, the where to purchase issue is not really that big of a deal in the sense that we have dispensaries in many places, but there are still quite a few municipalities who have said we do not want cannabis dispensaries in our borders. And then, of course, lack of healthcare provider knowledge. So um, these data are now a few years old, but in that same cohort of 1,300 individuals, we asked people with chronic pain how they selected cannabis products, and most did not consult with any kind of medical provider versus over half consulting with a bud tender. Um, Similarly, with CBD products, most looked at their personal research or they asked for advice from an employee at the place of purchase versus just 16% due to endorsement of a medical professional. And in a survey that my colleagues and I conducted among cannabis dispensary patrons, we asked them, hey, so you substituted cannabis for these different products. What were your influences for substituting cannabis, say, for opioids or benzodiazepines or whatever it might be? And most people drew on their own personal experiences rather than the advice or support of a healthcare provider. And so that suggests also that there's a gap in both in disclosing, but as well as what the amount of influence that providers are having in these sorts of decisions that are made around health. Now, on the other side of the coin, we surveyed healthcare providers, over 200 physicians, and asked them standard questions about cannabis as well as about their confidence and comfort around cannabis. And they generally reported a lack of confidence and comfort in their own knowledge and ability to integrate cannabis into treatment. Very few said that they're moderately or extremely knowledgeable about cannabis, and only 18% said they're somewhat or very comfortable incorporating cannabis into treatment, while over 60% were somewhat or very uncomfortable. And for the questions we asked that were drawn from the scientific literature, like these are known things about cannabis, only 58% of questions on risks, benefits, and cannabinoid effects were accurately answered. So, in summary, we know people are using cannabis for pain, but trials are limited. We know people substitute cannabis for pain medications, and they use a wide variety of cannabis products in a way that's not congruent with clinical trials. This means, and also that cannabis is poorly integrated into mainstream medicine, but I think it can be done better. And that's one of the reasons that I was excited to present today. Um, so my colleagues and I published this paper a couple years ago about thoughtfully integrating cannabis into chronic pain treatment. And drawing from this, we've come up with some tips as well as a couple novel studies of how to work with cannabis in the pain context. So in terms of tips, developing a treatment plan with symptom tracking, especially when working with one's physician, um, defining treatment success and failure, the symptoms of interest, and how use is actually being measured, I think are incredibly important to do here. Focusing on both harm reduction, so things like, well, you should ideally avoid smoking if you can, as well as use when driving or at work or things of that nature, but also benefit maximization. So thinking about how one might tailor use to their specific symptoms to maximize success. These include some pretty practical strategies like start low and going slow, both in terms of dosage, but as well as starting with CBD, which is not intoxicating, before going to THC, which has those more intoxicating effects. Considering different routes of administration, so if somebody has elbow or knuckle pain, probably the lowest risk thing to do would be to try a topical on those rather than taking a gummy or something like that that has systemic effects. So maximizing the benefit of a local effect. Being thoughtful of one's environment and mindset going into use. Um, this is the same idea of set and setting that people talk about in other spaces as well, that is incredibly important here. and then aligning timing of use with symptoms. So, if somebody really wants to use cannabis for sleep, that use should ideally be tied into that period of when they're trying to sleep rather than, say, smoking joints all day. And then building partnership with care providers. And lastly, as I've already talked about, thinking about potential legal ramifications. And so I'll just take a last minute here to talk about how we've tried to operationalize these in a study that we're doing funded through the Cannabis Regulatory Agency here in Michigan. It's called the Michigan Veterans Cannabis Program. And I'll talk a little bit about this Blue Box Intervention 2, where participants are receiving one-on-one coaching to help them optimize their cannabis use to maximize benefit and minimize harm. So we published the results of our feasibility study in early 2025. Because we're not giving people cannabis products, this did not require FDA approval or investigational new drug application. We had 22 participants. And participants really enjoyed this intervention. They found it to be very helpful. They were very satisfied. They really noted the value in developing a personalized plan for their own symptoms, the ability to discuss questions and concerns, and the flexibility to try different approaches. Using the patient global impression of change, over 60% of them said that their pain was very much or much improved, which is considered clinically significant. And they also reported statistically and clinically significant improvements in both pain intensity and pain interference. So we're following this up in a large trial. Obviously, it's a pilot study. There's a lot to still be figured out, but knowing that this is both a legal and a legal way to go about this research, as well as one that patients were so interested in, was really exciting and encouraging. So the last words that I will leave you with before questions then, this came from an article published in the UK, but the idea of contextualizing cannabis in the way that we think about any medicine. So every time a medicine is prescribed, an N=1 experiment is being conducted. In some patients, the experiment works, and in others, it fails. Cannabis is no different. So with that, thank you for your kind attention and looking forward to any questions you might have.
Thank you, Dr. Boehnke, for that. Oh, yep, wonderful presentation. So we are now going to open it up for questions. We do just have a couple minutes, so hopefully we can fit in some questions. Again, we do ask that you ask all of your questions or submit them through the Q&A function, which can be found at the bottom of the screen. You can also click on the thumbs up icon under a question that someone else already asked if you have the same question, and this can help us prioritize questions if we don't have time to get to all of them. So, and now I'm trying to bring back up the questions here. So, one of the first questions we had is, how does someone find a medical provider with knowledge of cannabis?
It's a great question. Well, one way to do so is to ask your current medical provider if they have any knowledge of cannabis and their comfort with that, especially if it's somebody that you've been seeing for quite some time in the medical space. Ideally, you would be able to work with somebody who knows you, who knows your body, who knows what you're working with, because that way you have some of that partnership already in place. Now, there are definitely some situations where people, like I mentioned, where people will disclose cannabis use and their doctor will say, I'm not going to talk to you about that. And so in those cases, it can be difficult to know how to proceed. Unfortunately, I don't have any other like hot tips on how to specifically find medical providers with knowledge of cannabis. You could look on people's websites. There are some individuals and some specialists who specifically say, hey, cannabis consulting is my thing. This is what I do. I will incorporate cannabis into your treatment regimen, but that's not something that that I've seen as standard so far, and I definitely have not seen like a large number of medical practices that focus on that. So I wish I had better info for you, but I think starting out with that initial like talk to the people who you already know and trust. And even if they say, hey, I don't have much knowledge of it, maybe they can be one of the nodes in um, your treatment network and either provide a recommendation or stay in the loop as one is trying to start out and build this knowledge and self-understanding, I should say.
Thank you. Another question we have is, are you able to comment on cannabis for neurological conditions such as RLS?
So I'm not sure what RLS stands for, if it's some kind of lateral sclerosis or what it might be, but for neurological conditions, so like multiple sclerosis, for example, there's been quite a lot of work done in neuropathic pain related to multiple sclerosis. Um, that's where some of those studies were done with that one sublingual spray called nabiximols. It also showed some potential benefit in multiple sclerosis related muscle spasticity. So promising information there. But for other neurological conditions, there just hasn't been the same amount of work that has been done. This is one of those situations where, because, again, I don't want to sound like a broken record, but the limitations imposed by the Schedule 1 status of cannabis have been quite limited. Uh, uh, in terms of the all the conditions that have been studied. Like if we discovered the cannabis plant today and we are like, wow, this is amazing. There's so much that we could do with this plant. RLS is restless leg syndrome. Thank you for that. I've seen very few studies with restless leg syndrome. Um, but yeah, if we discovered the cannabis plant today and we were like, oh, this has a lot of potential. Let's pursue this fully. We could go a lot faster than we had done in the past.
Right. And one last question. Have you come across any conditions where cannabis can make the pain worse, if not during the actual use, but the next day?
Yeah, I love this question. So I'd say less when it comes to the condition itself. But this is something that seems to be potentially more related to one's individual characteristics. So, um, and this is the case with many different medications as well, but there's sort of a non-monotonic curve. So when people dial in the amount that they're taking that is the right amount to cause some amount of symptom relief with minimized side effects. If people take less than that, then maybe they don't get appropriate symptom relief. But if they take more than that, either the side effects outweigh benefit or it actually stops being less helpful. And so there's a couple clinical trials that have demonstrated that at higher doses, um, cannabis seems to, rather than being analgesic, may increase the pain a little bit. Um, these are small, more experimental studies, but it's also important to think of context here too. So often people with pain have pretty intense sleep disturbances, and cannabis can interfere with sleep, especially when taking too much of it. So, if somebody took cannabis hoping to get a good night of sleep, that would then help downstream with their pain, but they ended up tossing and turning all night because they overdosed, not lethally, but they just took too much and it negatively impacted their sleep, then their pain might subsequently be worse. And similarly with mood, like people take too much, especially THC containing cannabis, that can potentially result in higher levels of anxiety. And that anxiety can then feedback spiral into worsening pain symptoms. So, not condition specific, but individual and contextually related issues with that worsening of pain.
Thank you. We do have a couple more great questions, but I want to make sure to leave time for to share the evaluation for anyone who does need to end just at 1 p.m. But I can, if you have time, Dr. Boehnke, to after I share the evaluation, to answer maybe the last few questions, and anyone who wants to hang out and has the time. Otherwise, people can always reach out to Dr. Boehnke directly via email to follow up on the questions. So in terms of evaluation, just a